Welcome everyone to the Buncke Clinic Virtual Visiting Professor Series. On behalf of my partners, Drs. Greg Buncke, Rudy Buntick, Andrew Watt, and Walter Lin, I'd like to welcome you to this afternoon or this evening's talk. We have the pleasure of welcoming a very dear friend of mine, Mauricio Mendieta from Managua, Nicaragua. Dr. Mendieta is the Medical Director of Plastic and Reconstructive Surgery at Hospital Vivian Pelas, and he's also the Academic and CME Director of the Latin American Society for Microsurgery, ALAM. And in this capacity, we've actually had the pleasure of working together on a few projects, which you'll just hear about in just a minute. So as I mentioned, he's the medical director of plastic surgery at his hospital. He's also director of the microsurgery chapter of the Ibero Latin American Federation of Plastic Surgery from 2020 to 2022. He is the academic and CME director of ALAM for 2 years, from 2019 to 2021. He's a national delegate of the International Confederation of Plastic Surgery Societies, ICOPLAST, for the past 4 years, including this year. He's an associate editor of PRS Global Open for 3 years, from 2018 to 2021. And last but not least, obviously, he's the past president of the Nicaragua Plastic Surgery Society from 2017 to 2019. I had the pleasure of meeting Mauricio in Patagonia, actually. Well, I'd met him before, but spending more time with him. You've probably heard me talk about this when we had Professor Stefan Hofer and also Andres Rodriguez from Sweden on. I also had the pleasure of spending time with them at the first Patagonia microsurgery meeting that we had last year. We were supposed to have one, as you can see here, in 2020, but unfortunately that got postponed for the Chilean riots. But we also had COVID after that, so it was just a doomed year for many reasons. But this was really a fantastic meeting, bringing in a lot of really great faculty and also a lot of great attendees from all over Latin America. And here is Mauricio here on the end there. And it was really a great time to not only give lectures, but do cadaver labs and teach sessions. So really a fantastic group. You've already heard from JP Hong right there, Stefan Hofer, Andres Rodriguez, and you will hear from Evan Garfine later. And obviously tonight you'll be hearing from Dr. Mendieta. I've had the pleasure of working with Mauricio as well in a joint program between ASRM and ALAM, which will air on August 22nd of this year. And this was all entirely Mauricio's idea, along with Professor Alex Cardenas, who will be speaking tomorrow to us. And this is really the first combined virtual format presentation between the two groups. And we're bringing together worldwide experts talking about innovations in microsurgery, as well as a video session for flap harvesting. So stay tuned for that, and a lot more detail will go out on social media, I'm sure, over the next couple of months. So with that, Mauricio, thank you so much for being with us. It's really an honor and a pleasure to have you, and we're all looking forward to hearing your discussion of lower extremity injuries. I'm going to make you a presenter right now, and we'll get started.
Thank you, Babak. The pleasure is all mine. I will turn off the camera, or even though I'm all dressed up for the visit.
Actually, keep your camera on, because GoToMeeting, when we record the videos, it actually has your video next to the presentation. Otherwise, it'll just be blank. So that'll be great.
Okay.
Perfect.
Perfect. Okay. So thank you very much for the invitation. It's really an honor for me being at the Buncke Clinic as a visiting professor. I come from I did my residency at the General Hospital of Mexico, and our program director, Dr. Nicolas Sastre, seated us with all the knowledge he had upon microsurgery. From this hospital, I did also my microsurgery training. And Dr. Nicolas Sastre, in one part of history, was a part of the Buncke Clinic. He attended in the 1975 with Dr. Harry Buncke to train in microsurgery. And you can see in this picture in the 1990, Dr. Nicolas Sastre and Dr. Harry Buncke were at the International Symposium of Experimental Microsurgery in Mexico City. This picture was taken in the National Palace of Medicine that is in the center of Mexico. That is called El Zócalo. And at the right side, you can see also Dr. Jose Luis Haddad, who also trained in the Buncke Clinic. So all the Buncke Clinic experience was transferred to us as residents and also as microsurgery trainees. And all the attendants also received this education. Here's Dr. Raimundo Priego, who also I had the pleasure to see, and he taught me a lot of the things that I actually practice. So it's truly an honor to be at the Buncke Clinic. So with that said, okay, I'm going to talk about the evolution in flap selection for lower extremity reconstruction. Although I, after my training in plastic surgery, did a fellow in breast reconstruction. When I arrived to Nicaragua, I started working at the military hospital. Okay, and at the military hospital, all we had were lower extremity cases. So that led me to practice more the lower extremity. So I have no disclosure for this talk. And well, my objectives and goal for this talk is to talk about some anatomic considerations, how do I do the injury assessment and the reconstruction principles I follow, and which leads to the flap selection and the technical aspects that we do on the surgery. When we talk about reconstruction considerations, we think about all these questions, but actually we've seen that what prevails mostly is the function, the aesthetics, also the sensitivity we have upon the lower leg, and ultimately it's about donor side. Okay, donor side is to have primary closures of those donor sites and not having any biomechanical injuries due to the take of the flaps. And we have to ask ourselves if the same solution for all injuries. Well, a Nobel Prize, Santiago Ramon and Cajal, said there are no small problems. Problems that appear small are large problems that are not understood. And that, I think, applies to lower extremity reconstruction, when sometimes we see small wounds that we think like with a local or a small flap we can solve the problem, and after a time the wound tends to break down. So we have to assess this. And in flap evolution, John McCraw always said, flap surgery is little like playing a chess game, that designed by a sardonic nature who does not reveal all the rules of the game. In 1986, they said, well, we don't fully understand what the delay phenomenon, what leads to obstruction, what has to do with the temperature of the flap if it's cold, and spasm. So we didn't know a lot of microcirculation and how this was done. But actually in our times, we can see also the cross-leg flaps method popularized by Stark, and who was presented in the 1951 ASPS annual meeting. And we know cross-leg flaps approach would require approximately 2 months to complete reconstruction, where the flap approach would achieve with a free flap definitive reconstruction in a single injury, providing early ambulation. And it may be an option due to the lack of proper recipient vessels and breach the circulation in some cases. So sometimes we still see this kind of flaps. But leg sometimes is not that grateful. Okay, in contradiction to other bodily regions, the inherent characteristic of lower extremity can turn simple defects into a major challenge, and the cutaneous coverage can be done with success with the proper vascular tissue. This characteristic is that we have paucity of the soft tissues, we have bony prominence, and the diameter going from a bigger width to a lower circumference, that it's a weight-bearing structure, that it follows the biomechanics and are prone to vascular disease. The venous, the deep venous system, as we know, is controlled primarily by the pumps of the muscles that take action every day. And also the trauma may disrupt the potential perforators that we use for the reconstruction. And the reconstruction principles, there are factors to consider, in which the most important are obviously the size of the defect, the grade of the injury, the contamination, and these have to be considered. The main goal is to make the coverage in the first 7 days to lower the chance of infection, non-union fractures, and osteomyelitis. Preservation and the balance of osteocartilaginous defects and muscles are of great importance also to restore the biomechanics. The concept of zone of injury, as we know, many lower extremity wounds resulting from high energy injuries are with a substantial zone of injury. This is a thrombogenic zone and is known to extend beyond what is macroscopically evident. And they taught us that the anastomosis or the safe zone will be proximal or distal to the injury. But this concept is constantly right now changing because we have to see the zone of injury in a three-dimensional way. And some authors have pointed out that we could have recipient vessels in the zone of injury for a free flap. And not to be overlooked is that I think the most important principle upon any reconstructive surgery, and it was said by Marco Godina, who said debridement is, in our experience, that is crucial element of the operation with influence significantly in the final result. We sometimes send the resident to do the debridement, and is the step that is most important sometimes to do our reconstruction. They will give us the base to do and proper reconstruction. And as we know, anatomical and experimental studies have served as stimulus to some authors with a more precise description of the vascular territories, leading to the clinical development of different flaps with their indications, advantages, and disadvantages. These also the freestyle flaps that were in 1983 by Ascos Celayevera said that we had to do a dissection from the trunk to the leaves, and this was then changed by Professor Fushan Wei, who said that we should do from the leaves to the trunk. Okay, and we know also we have the reconstruction elevator. Okay, new studies also have shown us that each potential donor site and perforator has a unique quality that must be carefully analyzed before it's selected for a free flap, and more often a day as a local perforator flap. And depending on the extent of the injury, microsurgical flaps can also be reserved in our toolbox for reconstruction. In the refinements of the reconstructive ladder, we have the perforator flaps, which has led us to increase choices in flap selection. We can tailor the flap based on blood supply, and we have adjacent tissues to the defect also to incorporate into the reconstruction. It's said that it's a simpler method, and it has fewer revisions when we talk about perforator flaps. And what if we walk down the ladder? Okay, if we walk down the ladder, we can have local perforators who are simpler, a local solution, a like-with-like reconstruction, no need for a microscope, and it can be done in one team approach. But in the distal third of the limb, we also reserve the free flap. So we have multiple options for the, sorry about that. And the choice of flap to be used for wound coverage is determined also, as we know, by the size sometimes. Although fasciocutaneous flaps are more tolerant than muscle for secondary procedures such as a plate removal or bone grafting, it also has been mentioned that fasciocutaneous flaps that provide skins contribute to better venous and lymphatic drainage. And therefore, the risk of distal lymphedema, in theory, is decreased. But what about them if it has to be muscular or facial component? Okay, wound debridement and early flap coverage and achieves infection-free union, and it has to be selection upon requirements. One disadvantage that I would point out of the fascicutaneous flaps is that they decrease ability to adhere to bone, and the muscle flaps tend to adhere more to the bone and obliterate the spaces. So we have a lot of flaps that we can use in different situations, but we have to look at the size of the defect, what if we have those dead spaces, and which flap we have to use. The thinner the flap in soft tissue reconstruction is going to be better. So this is where the high energy traumas, for example, like this case that was referred to us on this weekend, we can see that it had only he had a fracture 3B of Gostillo, and it had a fasciotomy and also a femur fracture. So we have to also see for all those injuries that are in the lower extremity to do the secondary procedure, in this case the free flap, in the right time. And before surgery, we have to plan ahead. Okay, we have to look at the etiology, if it's an oncologic case or if it's trauma, see the transition zones between the leg itself. If we have to rely on the orthopedics team, that I will advise to work all with the orthopedics every time and have a great communication between both. If we have to do combined procedures, see the perfusion we have up on in the extremity, if we have good recipient vessels, and the time frame to do it. Although we try to do it 7 days before after the trauma, sometimes this in our settings cannot be done. We get a lot of referrals from failed flaps, actually, and that are being, for example, exposed structure for at least 2 to 3 weeks. And also to do one-stage procedure if possible, and why not look for perfection from the first time we do it. And muscle regional flaps, as we know, they have lower extremity. In the lower extremity, the biomechanics, we can look at 10% loss of jumping power. Also, the arc of rotation is limited to the proximal third, talking about the gastrocnemius, but it can obliterate the three-dimensional spaces. When we talk about the soleus, we also have to see that we are going to have a great coverage, okay, of the mid-third, but we are weakening the extremity itself. And sometimes this is not good, especially in patients of high age. So the free flap scenarios, we all know the indications, and it was written by Angel and Professor Wei. Well, the indications are large segmental bone losses, if we have mold losses, muscle loss, osteomyelitis, bony non-unions, tumor excision, irradiated wounds, burns, or peripheral vascular disease. As I did my first cases, I always thought of thin flaps when I was doing the reconstruction for the foot and lower extremity, because this has shown us that the patient won't need a special shoe or having to wear a croc for and be a stable coverage. So one flap that we used to do a lot was the radial forearm flap for this kind of injuries. And although at that time we didn't have a microscope, so we have to do it under loop magnification. And for the dorsum of the foot also, we think the radial forearm flap works really nice because of the thinness that it has, and it's large pedicle that we can do the anastomosis this proximal to the defect in a good manner. When we talk about the stability and durability, I also started doing what in probably all Latin America we do is the sural flap, okay, based distally. But what if we could add some sensitivity to this flap? So we described this a long time ago, well, actually 7 years ago, in which we included the sural nerve in the pedicle, in the fascicutaneous pedicle, and then in a second time when we are dividing it, we did an anastomosis of the sural nerve to the intermedial dorsal cutaneous branch of the superficial peroneal nerve, and this we thought it gave a little bit of sensitivity to this area. But then it came the perforator flap era, and Dr. Morris, who I had the pleasure to meet, he said and wrote about us about this more clearly, and he said, well, in the lower extremity we have 93 perforators from 21 vascular territories, so why not use this as the position, the possible flaps and donor sites for the reconstruction. And this theory also was, and to plan a flap, we have to follow these principles that were written by Saint-Cyr in the perforasome theory, in which this can lead us to have a flap that should be oriented along the axis of the main source vessel, or a line connecting the two perforators and within the main axis parallel to the axis of the body areas that are transverse in the trunk and longitudinal in the limbs. And also the third principle, the preferential filling of a perforasome occurs within perforators of the same source artery first, followed by perforators of adjacent source arteries. So it's important to follow these principles. And we use mainly now the ALT flap because it's relative constant anatomy. It has a long pedicle. The thickness tends to be more actually than the Asian patients. And in overweight patients, the flap may require a secondary debulking procedure if it's not done in the same time of surgery, doing a thin flap. And it give us great dimensions, design in the versatility and thinning. So with this flap, we can cover wounds for example, in this case, in the knee, that we had an exposed hardware of the replacement. So we did an ALT from the contralateral thigh to cover this area. And in the when the size of the tibial wound, for example, in the distal third of the leg is greater than 50 centimeters square, free tissue chamfers should be chosen in these cases. This can't be solved with a regional flap probably. And this is the stable coverage that ALT has in this case. And also we have, as I said before, failed cases that are chronic with exposed hardware, who've had a lot of failed flaps, and we can see poor surrounding tissues with scars. So it's here the free flaps, the ALT works really nice here with two perforators that was brought down with the flap, and do a stable coverage of the defect. And for the plantar foot, okay, this is a weight-bearing area, so it's important to do a neurotype flap. So in this case, we included the lateral femoral cutaneous nerve to give sensation. And sometimes in the hindfoot, for example, in this case of a chronic ulcer, this is a weight-bearing area also. And this patient has a sad history. He had an accident 30 years ago, actually, when he had a wound in this area, and he he was treated with a cross-leg flap, but the cross-leg flap failed, and the good extremity ended up in an amputation, and this never healed over 30 years. And as we see in this study, and we can see the other leg that is missing due to the amputation that was the good leg, we can see in the vascular status of this study that basically we have an anterior tibial artery, the posterior tibial artery, and that's the problem why he had a chronic ulcer and never healed. So we, in this case, had the mission, okay, to do one surgery, one just we had one chance to get it right. But since we saw that also that the posterior tibial artery has some kind of flow, we exposed them and thought about why not doing the anastomosis here and playing it safe, not to sacrifice the anterior tibial artery where all the main circulation of the foot was. And we should do it ETE or ETS, okay? Well, if it's not a predominant artery right now on the leg, we did the end-to-end anastomosis, and also we did 2 veins, the artery, and also you can see here in the lower part, we put it on the nerve coaptation. So with this, we had a stable result. It is an early post-op, 3 months out. And what the benefit of doing the neurotization? Well, the last study done, published this year in the 2020, said that neurotized free flaps appear to have an overall decreased rate of ulceration, improved sensory discrimination, and quick return to ambulatory activities and daily living in comparison to non-neurotized free flaps. However, they said that when examining the free ALT and the free medial plantar artery flap, durability and functionality do not appear to be significant difference between neurotized and non-neurotized flaps. Another variation of the ALT is the retrograded flow, that it can be based distally, and it was described by Sang. And the pivot point at the anastomosis is at the anastomotic connection between the descending branch of the lateral femoral circumflex artery and the lateral superior artery or the profunda femoral artery, approximately 3 to 10 centimeters above the patella. With this, we can cover the defect. This is the flap already clamped at the proximal artery in the LCFA, and we can see that we can do the coverage in a good way in this kind of defects. For the proximal leg exposed tibia, we also have the medial sural artery perforator flap, who was described by Montegut, but who really popularized it was Pedro Cavadas. And we can see we have a nice pedicle for this and transpose it without taking any muscle. And one thing about doing perforator flaps, if you're going to do it pedicle, you always have it to plan it like a free flap. We have to have a long pedicle. To avoid the kinking, to have a good transposition, a better arc of rotation. And although it's good, I wouldn't advise it to do it, for example, in cases that we can't close the donor site in a primary fashion, because the grafting of the donor site, it doesn't look good aesthetically, especially in women. We know the medial sural artery perforator flap has gained some popularity in some places, and actually for tongue reconstruction goes very good. in compare with the radial forearm flap or the ALT flap. But for the mid third of the leg, always think first of donor side, how it's going to look after we transfer the flap. And well, then we go from to the propeller flaps, okay? And this was described by Hyokusuku in 1991, and described a method in which a flap was rotated with, in which the length exceeds the width based on a central subcutaneous pedicle with an orientation of 90 degrees. And I had the pleasure to know Dr. Stephen Morris in 2012, and in that time I was doing a lot of leg reconstruction. So he said, well, one thing we can do are the propeller flaps. So I'll invite you to the Duke's breast perforator flap that is next year, 5 months after the meeting where we met. And actually, I went there, although it was for breast perforator reconstructions, and we can see Buncke Clinic faculty at the right. In the free time, Dr. Stephen Morris showed me how to do the flaps in the fresh cadavers, and that was how I incorporated the perforator propeller flaps for my toolbox. And the propeller flap concept was refined actually by Theo, and it has allowed us to cover areas previously considered as unreachable based on local flaps from perforators in the vicinity of the wound, preserving the integrity of the 3 vascular axes of the leg and the muscle underneath, and avoiding the need for an anastomosis and the benefit of importing truly undamaged tissue into the primary defect. These flaps have 4 characteristics. There is a predictable and consistent blood supply, at least 1 perforator vessel greater than 0.5 millimeters, a long pedicle for the transposition required, and the ability to close the donor site primarily. And it gives us a stable coverage. One particular characteristic of this type of flap is that it offers the same tissue thickness and appearance of the surrounding tissues, making it and providing a stable coverage. And as Albert Einstein said, everything should be made as simple as possible, but not simpler. So this is a great way to solve this kind of problems. And where do we locate these perforators? Okay, what we do is we use an acoustic Doppler with an 8 megahertz probe that have shown a sensitivity of 87% and a predictive positive value of 93. We can sometimes have two perforators close to each other, like in this case of the posterior tibial artery, and we have to select the closest one or the one that has a better perfusion to nourish the flap. Because if we choose the one that is more proximal, we'll probably end up with a big flap and a big scar and wouldn't get to cover the defect. This is how we do the Doppler. We locate the perforator adjacent to the defect. Okay, so, and here in blue is the border of the tibia, and we can see this small perforator that probably comes from the posterior tibial artery, but we can name it also as a freestyle flap. And always try to follow the axis. And if you have the uncertainty of which vessel is better for the flap, clamp the vessel. Put a neckline clamp in the perforators and see how the flap edges tends to bleed. Also, remember to release the fascial strands from the perforator vessels. It's very important, this step. And stay away from scars as well. Not to incorporate, like in this case, the scar that it's going to be done. This is a freestyle perforator flap. and where we located a perforator, and it's between two articulations, so that give us a bidirectional flow of the flap. And this is how we do the small suprafascial dissection. And as you can see, we open a little bit the fascia, so we didn't have any problems. You can see here how the fascia is open, and we don't see the source vessel. That's all we need to transpose the flap and guarantee that it will have a good perfusion and the donor side will be primary closed. In the 2017, we described a series of these cases, and we found out, for example, always you have to look for this superficial venous system. If it has a superficial venous system within the flap, it's better to do a Doppler beforehand, because the dominant or the problem that you can have after transposing the flap is venous congestion. Why? Because these two vessels run within the flap, so we have to restore that. And a recent published paper said the comparison of propeller perforator flaps and venous supercharge for perforator flaps, and the direction of flow in recipient veins, if it's antegrade or retrograde, was never considered as a problem. Authors used to obtain maximum usable length for this, and the venous anastomosis were done in either antegrade or retrograde direction. And it seems that when the pressure progressively increases in the flap, the drainage in the distal veins takes place whatever the initial direction of the flow. So in the recipient side, we can sometimes find a vessel, a vein, and that vein should be used to supercharge our propeller perforator flap. This is how we, for example, when we do the liberation of all the dissection, we can see here that this is two small veins that actually is our outflow monitor. And once we take out the clamps, we can see how the edges of and perfusion of the flap is. We can see how the flaps, for example, have the adequate perfusion for it. And is fascia, we can do this also suprafascially or with the fascia. And my advice, for example, if it's the fascia, where can we preserve it? Was most definitely at the mid-third of the leg, or where we have large muscles, because that will prevent herniation of the muscle, and the bumps that we talked about early on in the talk won't be damaged if we take the fascia, and biomechanics of this pump will be working effectively. What are the safe dimensions for this? We did a study in the 2017 about 30 cases. We reported these kind of papers at that time were not that popular. And we found that 48 centimeters was the average we had in this case series. Yesterday, I was reading an eFirst systematic review in which they say that reoperation rate was significantly higher for skeletonized flaps with length to width ratios greater than 1.75 and a flap size over 48 centimeters square. That is consistent with what one would accept given the knowledge of the perforasomes and blood supply of perforator flaps. So less than 50 centimeters in lower extremity, I think we're good as I mentioned. Here is a case of a posterior tibial artery perforator flap. It's not a freestyle. And we can see also here the little vein that is proximal try to preserve it. Although it's a little bit tiny, it can work sometimes to improve the drainage of the flap. And an important step in doing the propeller flaps is also to leave the propeller flap rest when it has been released in the 360 degrees and underneath. Leave it there in its native position for 10 minutes and see how the perfusion of the flap tends to do. If it has a good flow, then you can proceed with the transposition of it. Here is the pedicle of this flap, as you can see, is of 2.8 centimeters, and that is a safe dissection to transpose this flap with a 16 by 5 and 180 rotation. And as I mentioned, donor side. It's really important to close that donor side effectively. Here's the post-op. And the distal extremity defects, okay, for this kind of flaps, we can do them, okay, as well. Although it's not advisable to cross over bony prominence. And also in another paper we published in PRS Global Open, the more distantly you go, it's more difficult to close the donor side. And we'll have these kinds of graphs that don't look that good, for example. So try to prevent to do these kinds of flaps probably because of the donor side appearance in these kind of cases. And beware of the comorbidities. This is a case we also did. We have an epidermolysis. In complications, it seems in these flaps to be up to 25% in some series, but we've seen that patients older than 60 years that have diabetes, arteriopathy, or smoking status, we shouldn't be doing these kinds of flaps and select a better flap, even a free flap for this kind of coverage. And if you have the malleolus or any bony prominence, okay, I think the best way to do it is think freely. Do free flaps, thin flaps. I think they have a better result for this. And in conclusion, and okay, also, what about the free muscle flaps? I know at the Buncke Clinic they do a lot of free muscle flaps. My reasons are not based in evidence-based medicine or clinical scenarios why I don't do it. And it's because I don't have that much patients with large defects or that are circumferential, no degloving injuries below the knee, the donor side weakness for support. We don't have them here and have no rehab for those patients that probably need crouches. Also, if it has to do because of the education center where we did it, well, actually, I saw in my residency and when I was doing the microsurgery, a lot of abdominal rectal free flaps for lower extremity, also, as well as latissimus dorsi. But I feel ALT has me covered for this kind of injuries. So in conclusions, I will say that the zone of injury assessment and treatment is essential to have a good result. You have to evaluate the vascular status of the extremity, and local perforator flaps are good for small to medium defects, no greater than 48 to 50 centimeters. Large defects, microsurgical perforator flaps have a less donor side morbidity, and the dissection of the pedicle perforator flaps, always think it as a free flap. Another advice for the residents that are looking at this presentation is to always observe. As Alex Carrell said, a few observations and much reasoning led to error, but many observations and a little reasoning lead to the truth. So look for that pedicle, look for that perforator, and plan ahead for your reconstruction. Thank you very much.
Thank you so much, Mauricio. Fantastic talk. And as always, also delivered very professionally and very clearly. So thank you so much for that. I am going to, before I get to the questions, I just want to make this announcement here. We're doing a study on webinars with JP Hong, Tommy Chang, and Hina Rockhorst. And I just pasted a URL in the comment section. So I'm going to ask our viewers today if you can please paste that into your browser. It just takes a couple of minutes and fill out the survey. That would be great. Mauricio, thank you so much again. We really enjoyed your talk. I had a couple of questions that I'll open up to the audience for questions as well. The propeller flaps are very interesting, and as you know, we had another talk on that a few days ago. I saw that you obviously use the Doppler to identify the perforators. Do you have any experience using ultrasound technology in identifying the perforators and kind of seeing what kind of speed they have by any chance?
No, I don't have any experience with the duplex. The acoustic Doppler has worked fine with me. I think it's a useful tool, but I don't do it routinely. When I do for example, for these kinds of defects, sometimes I will send an ultrasound duplex, but not looking for the velocity of it, but for adjacent perforators that we can base our flap.
Got it. And the supercharging that you showed with the vanes makes a lot of sense, and I think we do that with some of our free flaps as well. What percentage of your perforator flaps would you estimate that you are supercharging?
I would say that every time I encounter a superficial vein within the flap, okay, in my dissection, I always do when I'm doing the dissection around the flap, if I see a vein here or a vein here, my first thought will be to supercharge the flap. So in the lower extremity, we have a lot of superficial venous system. So I would say probably around 15% of the cases I would do the supercharging.
15 or 50?
15.
15, okay, great.
Not much, right. Because also we have to look at the pedicle of the perforator. If we see, and if we dissect down to the main vessel, we have a deep venous system that will work beautifully for us. But if you're going more distal, the more problems of congestion and venous problems we can have. So probably in those cases, I will advise the supercharging.
Got it. And then do you tend to supercharge the ones that are larger by any chance? Let's say you have a very large perforator or a propeller flap. Would you preferentially want to supercharge those just in case there's congestion? Can you hear me?
No, yes, I can hear you.
Sorry. So do you tend to supercharge more if the propeller flap is on the larger side? If it's a very large flap?
No, I stick with right now. I used to do propeller flaps, for example, for coverage here in the neck area, submental flaps, in the trunk. But actually, I feel more comfortable right now with free flaps. If the defect is too big, I will definitely go for a free flap, not a propeller flap. Also because of the donor side, we'll have long scars probably adjacent to the wound itself, and I wouldn't do a big flap, for example, or supercharge it.
Got it. And then any rough idea of, since I don't do propeller flaps, I do want to try them. Any idea on what the kind of partial loss rate is, or even complete loss in your hands?
Right now, the last series we did, it's around 30 patients, no, 32, and we have 3 partial necrosis of the 15%, less than 15% of the flap, and 1 epidermolysis. Okay, we didn't have any flap loss.
Got it. Great, thank you so much for that. And then my next question is about your free flaps, the free skin flaps, such as ALT. So even when we do, thinned ALTs, we feel like, for example, let's say the calcaneus or other areas that have very, very thin skin, you kind of tend to get that pin cushioned appearance where the circumferential scar almost makes the central portion of the flap much more prominent. What percentage would you estimate of your skin flaps are you having to go back and debulk or revise to get a nice contour? Any idea, roughly speaking?
I say 80%.
80%, got it.
Yes, that's a problem with these kind of flaps, and also although we do it the thinnest possible, you always have to go back and do a revision. For example, always for heel, when you're doing heel reconstruction.
Yeah.
Okay. That's something. For example, I know that over in the United States, they tend to do a lot of latissimus dorsi, and the results are beautiful. I mean, when you see them 1 year, 2 years out, it's almost like if they had no injury at all.
Yeah, no, I mean, I think we still do skin flaps too. Obviously, our preference usually is muscle for lower extremity, but I think our experience mirrors yours, and that when we do skin flaps, even when it's really thin, sometimes you have to go and do some revision to kind of get the contour exactly right. But they're still a very important tool, I think, in our arsenal for sure. Great. Looks like we don't have any questions in the comment section, so I think that's probably it for tonight. Mauricio, thank you so much for joining us again. It's great to see you. Obviously, not as good as seeing you in person, but I wanted to also again mention all the work that you've done on the combined symposium between ALAM and ASRM that's coming up in August. So I want to make sure people are aware of that and on the lookout. You'll get a lot more information in the coming weeks and next month about that. But anyway, thank you so much again. Great seeing you, and I hope to see you in person soon, hopefully.
Thank you for the invitation. It was really an honor.
Great, thank you so much. And for our viewers who are still on tomorrow morning at 7 a.m. Pacific time, Dr. Alex Cardenas from Mexico City will be discussing facial paralysis and his algorithm for that. And Mauricio, I will talk to you on Sunday about my program. All right, thanks everyone. Bye.
Have a good weekend.